So cardiac sarcoidosis clinically manifests in only 5% of the patients with a extracardiac sarcoidosis, meaning a pulmonary or a systemic sarcoidosis. Only approximately 5% of the patients have cardiac involvement. But on autopsy, the prevalence is much higher. Almost 25% of the patients with extracardiac sarcoidosis have myocardial involvement. That means majority of the patients probably are asymptomatic, therefore go undiagnosed. Most diseases occur in patients between 25 to 60 years of age. It rarely occurs less than 15 in patients of age less than 15 years or more than 70 years. It's more common in females than in males. The pathogenesis is basically an unknown trigger, which could be an environmental trigger or any infection, along with the genetic predisposition. The genes which are implicated is HLA-DQB601 and TNFA2. So along with these genes and environmental triggers and infections, it leads to an immunological response, that is immune dysregulation, basically activation of the CD4 plus T cells, the Th1 and the Th17 cells, and the release of cytokines, that is IL-2, interferon gamma, TNF alpha. Okay, all these cytokines get released in response to environmental triggers along with the genetic predisposition, and leads to formation of non-caseating granulomas. And then these granulomas infiltrate the myocardium and lead to tissue damage, remodeling of the myocardium, and lead to the clinical manifestations. So initially you have the early inflammatory state where the epithelioid cells and the multinucleate giant cells, the lymphocytes, the fibroblasts are forming the granulomas. Then you have the formation of the granulomas, non-caseating granulomas, which infiltrate the myocardium, cause tissue damage, cause remodeling, and ultimately it undergoes fibrosis. So there's a late fibrotic stage where the inflammation may still be active. Okay. So what are the phenotypes of cardiac sarcoidosis? Either the patient can be completely asymptomatic and be diagnosed directly at autopsy, or it is cardiac sarcoidosis with dominant extracardiac manifestations and hardly any or no minimal cardiac symptoms, or the third phenotype can be a full-blown manifested cardiac sarcoidosis. So either asymptomatic or minimal symptoms and a predominant extracardiac sarcoidosis, or clinically manifest cardiac sarcoidosis with cardiac symptoms. So if cardiac symptoms are present, what are the symptoms that the patient of cardiac sarcoidosis will present to you with? So the most common symptom that the patient will present to you with is dyspnea. 50 to 70% of the patients present to you with dyspnea, followed by palpitations, fatigue, chest pain, pre-syncope, syncope, edema, or patient may present with a cardiac arrest. So the most common presentation is dyspnea, followed by palpitations, most likely AFib or a VT, followed by fatigue, then chest pain, then a syncope, pre-syncope, edema, cardiac arrest. The most common site of where we find these sarcoid granulomas within the heart is the LV free wall, the left ventricular free wall, the interventricular septum, the RV free wall, the right atrium, and the left ventricle. So start with the LV free wall and go in the anti-clockwise direction. So the LV free wall, most common site, 96% of patients will have sarcoid granulomas present in the LV free wall, followed by the interventricular septum, 73% patients will have it there, followed by the RV free wall, 46% will have it in the RV free wall, in the right atrium 11%, and in the left atrium 7%. So start from the LV free wall, anti-clockwise. LV free wall, IVS, or the interventricular septum, the RV free wall, the right atrium, and the left atrium. These are the descending order in which you will find these are the most common sites for sarcoid granuloma. What are the clinical features that the patient presents to you with? Clinical features depends upon where the sarcoid granulomas are present. Correct? If it is only the basal septum involvement and a very patchy involvement, the patient can be clinically silent because it's only a small part that is involved and it is patchy involvement. Correct? So the patient can be asymptomatic. If the interventricular septum gets involved, what is present in the interventricular septum? The EV node, right? So interventricular septum gets involved, patient may present to you with heart block. And that is the most common presentation that the patient will come to you with. If you have the sarcoid granulomas, they can form a focus that can undergo fibrosis. The sarcoid granuloma, they can form a focus for a re-entry within the ventricle. Correct? So if the sarcoid granulomas are present in the IBS and the left ventricle, along with the left ventricle, IBS yes, but along with the left ventricle, they can form a focus for re-entry and can lead to a re-entrant tachycardia or ventricular tachycardia. Correct? And if there is an extensive biventricular involvement, both the IBS is also involved, both the ventricles, left and the right ventricle, both are involved, then you can have a manifestation of everything, a heart block, a VT and heart failure. Mainly heart failure because the bilateral biventricular involvement is there. Because the IBS is involved, heart blocks, and because the left ventricle gets involved, it can also be a re-entry tachycardia, correct, or VT. So it can present as anything. So only a patchy involvement, clinically silent, involvement of the interventricular septum, heart block, most common presentation. Involvement of the ventricle along with the IBS can lead to a re-entry tachycardia, VT. And if there is extensive involvement, biventricular involvement plus the IBS involvement, patient can present you with heart failure, a VT, and or plus or minus heart block. So when will you suspect a patient to have a cardiac sarcoidosis? First, when the patient is referred to you with a histological or a clinical diagnosis of an extra cardiac sarcoidosis. Okay, so the patient already has a histological or a clinical diagnosis of extra cardiac sarcoidosis. So patient can have a myocardial involvement as well. That is when you suspect that he may have a myocardial involvement, so cardiac sarcoidosis. A young patient, age of less than 60, presents to you with an unexplained syncope or an unexplained new onset conduction system defect. Right? Syncope which is not explained by all other causes of syncope, and a new conduction defect which is not reversible, again not explained by any other cause. Similarly, a young patient with a aborted sudden cardiac arrest or a sustained VT which is again unexplained by a regular outflow tract VT, or the patient has no structural heart disease and still has presented to you with VT, no history of previous myocardial infarction, it's not a vesicular VT, it's not an outflow tract VT, it's an unexplained VT, right? So an unexplained sustained ventricular tachycardia and or an aborted sudden cardiac arrest. And if a patient presents to you with an unexplained cardiomyopathy, unexplained dilated, restrictive or arrhythmogenic cardiomyopathy, you're trying to find out the cause for cardiomyopathy basically. Again, cardiac sarcoidosis should be one of your differentials. So, 4 things or 4 situations when you will suspect cardiac sarcoidosis. 1, when there is a previous histological or a clinical diagnosis of extra cardiac sarcoidosis. A young patient presenting to you with a unexplained syncope or an unexplained new onset conduction system disorder. Any young patient presenting to you with a aborted sudden cardiac death or a sustained VT which is again not explained by the regular outflow tract VTs or a vesicular VT or the VT due to any structural heart disease. And in patients with an unexplained cardiomyopathy, dilated, restrictive or arrhythmogenic cardiomyopathy. So when you have suspected the patient, now you're going to screen the patient for cardiac sarcoidosis. How will you screen the patient? Now, a biopsy proven, if a patient has come to you with a biopsy proven or histological diagnosis of an extracardiac sarcoidosis, right? You will take the history. What will you take on the history? On the history, you will see the symptoms, right? What did we see? The most common symptom was dyspnea. So, followed by palpitations, right? Followed by fatigue, chest pain, syncope, pre-syncope. So, these are the things that you will ask for and look for. So, dyspnea, palpitation, fatigue, chest pain, syncope, history. Then, abnormal, you check for any abnormal ECG. What abnormalities can you find in an ECG? AV blocks. So type 2 or type 1 Mobitz blocks, third degree AV block, complete heart block. Okay, or any tachyarrhythmias. VT, a sustained VT can be the abnormality on the ECG. A fragmented QRS can be an abnormality on the ECG. Okay. Then abnormal echo. What will you find in the echo? If the LVF has gone down, or if there is a basal interventricular septal thinning. So all this we will come to. What abnormalities can you find in the ECG? What abnormalities can you find in the echo? We will come to all of that. So first, basically, you see, look for the history, ask for those symptoms. Any abnormality on the ECG, any abnormality on the echo. If not, then it's unlikely to be cardiac sarcoidosis. Okay, there's a very less likelihood that myocardial involvement is present in this patient. But if either one or more is positive, then there is a likelihood that there is myocardial involvement and there is cardiac sarcoidosis. So that is when you will do advanced imaging, a CMR, a cardiac MRI, or a FDG PET. Okay. So if there is an extra cardiac sarcoidosis which is proven, how will you look for cardiac sarcoidosis? You will see three things. You will look for the history, you will ask for the symptoms, you will see the abnormal ECG, if there's an abnormal echo. If not, less likely to be cardiac sarcoidosis. And if any one or more is present, then there is a likelihood of sarcoidosis, and you will do advanced imaging like a cardiac MRI or a FDG PET. So now, when I said ECG abnormalities, what abnormalities can you find in an ECG in a patient with cardiac sarcoidosis? One, like we said, there are heart blocks, correct? So a type 2 Mobitz 2 heart block or a third degree AV block, that is a complete heart block, okay, patient can present to you. These abnormalities can be present in the ECG. Second, you can have a VT, a pleomorphic VT, okay, not a monomorphic, pleomorphic VT. In a young patient, you should start suspecting cardiac sarcoidosis. And a fragmented QRS in the baseline ECG. Why is the QRS fragmented? Because there are granulomas within the myocardium. So during activation, it is not a normal activation. That is why it is fragmented, because of the granulomas that are present. And in a young patient with VT, when will you say that this is an idiopathic VT or this could be due to cardiac sarcoidosis? If there is a recurrence of the monomorphic VT, okay, if a young patient presents to you with recurrent VT episodes, but each VT episode, monomorphic VT, but each of that VT episode is distinct. The morphology of every VT episode is distinct from the index morphology. So every time the monomorphic VT's morphology is different. That is one thing when you will suspect that it is probably not an idiopathic VT, it is due to cardiac sarcoidosis. Or if the patient presents you in the first time only with a pleomorphic VT. What is a pleomorphic VT? A pleomorphic VT is defined as when there are two distinct morphologies of a monomorphic VT in the ECG. And when the patient is in normal sinus rhythm, there are subtle fractionations of the QRS that we saw, fragmented QRS because of granulomas. Okay, so a young patient presenting to you with VT, when to suspect cardiac sarcoidosis? is if there is recurrence of a monomorphic VT, which is different, whose morphology is different from the index morphology. Or second, if the patient presents you with a pleomorphic VT only. That means there are two different or a distinct morphology of monomorphic VT within the same ongoing VT. And there are subtle fragmentations or fragmented QRS, fractionations of the QRS complex during normal sinus rhythm because of the granulomas. Okay. And what are the echo abnormalities that you will see? So echo abnormalities, echo has a low sensitivity as such to pick up any abnormality, but the hallmark finding, if you find, that is highly specific. So what is the hallmark finding? Hallmark finding in cardiac sarcoidosis is thinning of the basal intraventricular septum. Okay, thinning of the basal IVS, and when the IVS is less than 6 millimeters, it is a classical finding. It is highly specific for cardiac sarcoidosis. It is associated with a poor prognosis. Okay, it is associated with a poor clinical outcome. It has a prognostic significance, and it is also a predictor of a delayed onset of LV dysfunction. Meaning, a patient who presents you with a normal EF but has a basal IVS thinning, and the basal IVS is less than 6 millimeters, the patient will develop LV dysfunction later in the next 5 to 10 years. Okay, so for the screening of cardiac sarcoidosis, what did we see? If a patient presents you with a biopsy proven extra cardiac sarcoidosis, we are going to see for the history, ECG abnormalities, echo abnormalities. History, all the symptoms that we asked for: dyspnea, palpitations, fatigue, chest pain, syncope. ECG abnormalities. What will you find in an ECG? You may find a complete heart block, you may find a pleomorphic VT or a monomorphic VT which is different from that of the index etiology, a fragmented QRS. Third, you have to look for echo abnormalities. What will you find in the echo? You may find a lot of things, where the most highly specific thing is basal IBS thinning, basal interventricular septum thinning, and if the thickness is less than 6 millimeters, it is highly specific, associated with poor clinical outcome, and even if the EF is normal at that time, it may progress to LV dysfunction in the next 5 to 10 years. If either of these three things, either of one of them is also positive, so cardiac symptoms, ECG abnormalities, echo abnormalities, there is a high likelihood that this may be cardiac sarcoidosis. You will do further imaging with cardiac MRI and FDG PET. And if these three symptoms are absent, or if these three things are negative, there is less likelihood that this patient has cardiac sarcoidosis. What other investigations do you do? There is less likelihood that this patient has cardiac sarcoidosis. Okay. What other investigations do you do? Other investigations include cardiac MRI. The hallmark finding that you see in cardiac MRI is a multifocal patchy involvement of the mid-wall and the subepicardium. That means LGE, you see LGE as a patchy multifocal involvement in the mid-wall and the subepicardial. Why multifocal and patchy? Because these granulomas are not present continuously, right? They will be present in one place, some other place. It's a multifocal and a patchy involvement of the mid-wall and the subepicardial. LGE also in the basal anteroseptum and the inferioseptum. And the hook sign pattern. The hook sign pattern is again a pattern of LGE that you see characteristically, which is highly suggestive of cardiac sarcoidosis. So it is characterized by a prominent involvement of the ventricular insertion points with a direct extension of that LGE across the septum into the ventricle. So when it is going from the septum into the ventricle, the LGE, okay, directly goes from the septum into the ventricle. That looks like a hook, extended hook. Okay, that is what is called as a hook sign pattern. So three things: LGE uptake, in the patchy multifocal uptake in the mid wall and the subepicardium, LGE uptake in the basal anteroseptum and the inferior septum, and the hook sign pattern. All these are characteristic of a cardiac MRI. Cardiac MRI is 80 to 85% sensitive and it has a moderate specificity. Another imaging that we do is a FDG PET. Okay, so FDG PET assesses what? It assesses the inflammation, because the FDG is going to be taken up into the tissues which are metabolically active. So it gives you the inflammation, and it also assesses the resting myocardial perfusion. Now, what do you do in an FDG PET? The preparation is what? Usually, physiologically, the cardiac muscles take up glucose, correct? So the physiological cardiac metabolism has to be switched to a low carbohydrate and a high fat diet, okay, for at least 2 days. So the glucose metabolism is switched off by switching to a low carbohydrate, high fat diet followed by fasting. And you prefer doing a whole body PET so that you can see also for the extra cardiac involvement. So what do you see? You see mismatch pattern, or basically a perfusion defect. Why? Because the granuloma has probably caused an impairment of the microcirculation. There has probably caused scarring and fibrosis there. So that is where there is a mismatch pattern. So myocardial perfusion mismatch you see. And like we saw, the FDG is uptaken in the places where there is active inflammation, correct? So this FDG PET, it lacks sensitivity as compared to MRI, okay? And it picks up the active disease. So the FDG is taken up where there is active inflammation, active metabolism, okay? Therefore, it is more useful to follow up the patients, not for diagnosing the patients, because there can be so many non-specific uptakes. And usually, there is a diagnostic failure in the FDG PET, mainly because the preparation is not proper, prior inappropriate pre-imaging preparation. So 10 to 15% of the FDG PET are a diagnostic failure. It has a low sensitivity as compared to MRI. Sensitivity is around 84% and the specificity is about 83%. And if there is no extra cardiac uptake, the specificity further decreases. Okay. And if there is a atrial FDG uptake, it means that the patient may develop atrial arrhythmias. The patient has a tendency to develop atrial arrhythmias because atrial cardiomyopathy or the sarcoid granulomas have gone and deposited in the atrium. So instead of a ventricular tachycardia, the patient may have a supraventricular tachycardia. Okay. So FDG PET, it gives you two things. One, active inflammation, where the FDG will be uptaken by the granulomas. It tells you about the active inflammation, active state of the disease. And second, it gives you the perfusion mismatch, because the granulomas are going to go and obstruct the microcirculation, or the inflammation is going to progress into becoming into a fibrotic stage. That's when you're going to have a perfusion defect. Okay. Then again, there is another imaging that can be done, that is a gallium Dutanac PET CT. This is more specific or more better. Why? Because this binds to the somatostatin receptors, SSTR2A receptors, on the inflammatory cells in the sarcoid granulomas. So these somatostatin receptors are present on the inflammatory cells in the sarcoid granulomas. And these SSTR receptors are not present on the myocardium. So there is no physiological uptake of this GA Dutanac by the myocardium. Okay, so the noise, that is the unnecessary elsewhere uptake, is reduced. That's why it has a very excellent diagnostic accuracy. Okay, so we saw the ECG abnormalities, echo abnormalities. Echo, not only the IBS basal thinning, also the speckle tracking and the GLS. The cardiac MRI with multifocal patchy involvement of the mid wall and the subepicardium, the basal anteroseptum and inferior septum, and the hook sign pattern. You saw the FDG PET, okay, which is not very specific because of the improper preparation, and two, because it gives you it's a better for a follow-up because it tells you about the active stage of the disease, the active inflammation. Okay, and then you also saw the gallium dotonac FDG PET, which binds to the somatostatin receptors on the inflammatory cells in the sarcoid granulomas, and there is no physiological uptake in the myocardium. That's why it has a very good diagnostic accuracy. Now, for diagnosis of cardiac sarcoidosis, you have two diagnostic criteria. One is a 2014 HRS diagnostic criteria for cardiac sarcoidosis. HRS is Heart Rhythm Society. Okay, so 2014 HRS criteria, either there is a definitive cardiac sarcoidosis, that means there is a histological diagnosis of cardiac sarcoidosis, or two, it is a probable cardiac sarcoidosis. In a probable cardiac sarcoidosis, you have made a clinical diagnosis of cardiac sarcoidosis. Then one of the three have to be positive. What? First, histological diagnosis of extra cardiac sarcoidosis should be present, and any one of the following. What? One is cardiomyopathy or an AV block which responds to immunosuppressants. That means there is some ongoing inflammation which is causing the cardiomyopathy or the AV block, and giving the immunosuppressant is suppressing that inflammation and leading to relieving of the symptoms. That means it is probably sarcoidosis. The granulomas are causing the inflammation, causing the cardiomyopathies or the AV blocks, and they are responsive to immunosuppression. So, cardiomyopathy or AV blocks responding to immunosuppressants, a sustained VT, which is maybe induced or spontaneous, a second degree type 2 AV block or a third degree AV block, which is called as a complete heart block, unexplained reduced LVEF of less than 40%, a patchy uptake on FDG PET, or LGE on CMR. You saw what was the characteristics: hook sign pattern, a patchy mid-wall and subepicardial LGE uptake, and uptake in the basal anteroseptum and inferoseptum. So the LGE on MRI, a patchy FDG uptake, and positive gallium uptake. So how do you remember these 7 points? One is clinical features. We saw how does the patient present. Either the patient is going to present to you with dyspnea. What is the cause for dyspnea? Cardiomyopathy, correct? LV dysfunction. So that is the first, cardiomyopathy. Then patient presents you with either a VT or a heart block. So both those things come second. Second, sustained VT. Third, second degree AV block or a complete heart block. Unexplained LVEF of less than 40%. These are your clinical signs, right? And your imaging patchy uptake on FDG, the LGE on CMR, and a positive gallium scan. So clinical findings, imaging. That's how we remember. Okay. So clinically, either a sustained VT, a second degree AV block or a third degree AV block. Then cardiomyopathy, that's unexplained reduced LVEF of less than 40. And both these things, the cardiomyopathy or the AV blocks responding to immunosuppressants. And then the imaging. Imaging is what? Patchy uptake on FDG, LGE on CMR, and a positive gallium uptake. And also, there should be exclusion of all other causes for these cardiac manifestations. Okay. So, the 2014 HRS diagnostic criteria. One is definitive cardiac sarcoidosis, that is histologically proven cardiac sarcoidosis. Then for a probable cardiac sarcoidosis, you have a extra cardiac sarcoidosis, histological presence of an extra cardiac sarcoidosis, and the presence of any one of the following. What? Clinical signs. Clinical signs: 1, sustained VT; 2, heart blocks; that is second degree or third degree AV blocks. 3. Cardiomyopathy, so LVF, unexplained LVF of less than 40%. 4. All these 3 things, that the AV block and the cardiomyopathies responding to immunosuppressants. And your imaging. So imaging, 5. Patchy uptake on FDG PET, 6. LGE on CMR, and 7. Positive gallium uptake. And exclusion of all other causes for these cardiac manifestations. So this is the 2014 HRS diagnostic criteria. The second criteria for diagnosis of cardiac sarcoidosis is the 2016 JCS criteria, the Japanese Cardiological Society criteria for diagnosis of cardiac sarcoidosis. That basically includes a major criteria and a minor criteria. Major criteria, again the same thing, remember the symptoms. What are the clinical symptoms? Dyspnea because of cardiomyopathy, right? So LV contractile function of less than 50% or any focal ventricular wall synergy, or you can say a focal regional wall abnormality. So LV function of less than 50 or a focal regional abnormality. Second, palpitations or arrhythmias, correct? So both the arrhythmias, the high degree AV block and a fatal ventricular arrhythmia. So 1, cardiomyopathy, 2, high grade AV block or a fatal ventricular arrhythmia, and then your imaging. Here on your imaging, 2 of them is the same like the HRS criteria. So LGE on CMR and FDG PET, a high trace of accumulation in the heart, a patchy high trace accumulation in the heart of FDG, correct? So these 2 are the same. The HRS criteria had a positive gallium uptake, which is not included in the JCS criteria. It is echo criteria which is included, that is the basal thinning of the interventricular septum, basal IVS thinning, or an abnormal ventricular wall anatomy, which includes a ventricular aneurysm or thinning of the upper or the middle interventricular septum or any regional wall thickening. Okay, so the major criteria includes LV contractile function of less than 50% or a focal ventricular or synergy, a high grade AV block or a fatal ventricular arrhythmia, FDG PET, high trace of accumulation of FDG in the heart, CMR, LGE seen on the cardiac MRI, and basal thinning of the interventricular septum or an abnormal ventricular wall anatomy, which includes a ventricular aneurysm, thinning of the middle or the upper IVS, or a regional wall thickening. So these are the major criteria. And minor criteria include ECG abnormalities. What ECG abnormalities did we see before? Either a complete heart block or a ventricular tachycardia, which is a pleomorphic tachycardia, or a monomorphic tachycardia with a morphology which is distinct from that of the index ventricular tachycardia morphology, or a fragmented QRS, or presence of abnormal Q waves or axis deviation. Second is a perfusion defect on SPECT. And third is an endomyocardial biopsy, in which you see monocyte infiltration and moderate or severe myocardial interstitial fibrosis. Cardiac sarcoidosis is diagnosed when either 2 or more major criteria are present, or 1 major and 2 or more minor criteria are present. If there is presence of clinical or histological diagnosis of an extra cardiac sarcoidosis, if yes, you do an endomyocardial biopsy. If endomyocardial biopsy is positive, then you have a histological diagnosis of extracardiac plus cardiac sarcoidosis. If endomyocardial biopsy is negative, but if there are more than 2 major criteria positive, then it is a clinical diagnosis of extracardiac plus cardiac sarcoidosis. If there is no histological diagnosis of extracardiac sarcoidosis, but there are more than 4 major criteria positive, including the FDG PET, then it is an isolated cardiac sarcoidosis with no extracardiac involvement. And if no, then it is unlikely to be cardiac sarcoidosis. So the two criteria are the 2014 HRS criteria and the 2016 GCS criteria. And the JCS, the Japanese Cardiological Society of India, says you do endomyocardial biopsy if there is a histological evidence of extracardiac sarcoidosis. So endomyocardial biopsy is basically done from the right ventricle. Now it has a very low sensitivity of 19 to 25% only, mainly because the granulomas are very patchy and they are multifocal. So you would possibly have to take biopsies from multiple sites in the RV to be able to get a positive yield. It's a very cumbersome procedure to take biopsy from multiple sites due to the patchy and multifocal nature. And the yield of the biopsy is very less, only 30 to 25%. How you can improve the yield is by doing a cardiac imaging assisted or intracardiac voltage mapping. So from the imaging, you know where the sarcoid granulomas are, or you do a voltage mapping, okay, that tells you where the sarcoid granulomas are, and with the help of these, so cardiac imaging guided or intracardiac voltage mapping guided biopsies you take. So it maps the areas, this voltage guide maps the areas of cardiac activities. The MRI will tell you the LGE, or the FDG PET will basically tell you the the active inflammation, and you take biopsies only from those areas. That is where the sensitivity is going to improve. It will give you a better yield. That is where the sensitivity improves to 50%. So typically 10 heart muscle biopsies need to be taken for a diagnostic endomyocardial biopsy for a suspected cardiac sarcoidosis. It is an invasive procedure with a very low diagnostic yield. Why? Because multiple patchy granulomas, it becomes difficult to diagnose. Okay, so that is why it is kept as a last resort in case of a diagnostic dilemma. And the risk of serious complications is less than 1%. After you take the biopsy, what do you see? The histopathological findings. You see non-caseating granulomas, non-necrotic granulomas that lack a peripheral surrounding of plasma cells, star-shaped inclusions, asteroid bodies, isolated giant cells, lymphocytic or granulocytic infiltration combined with myocardial fibrosis, sharply demarcated areas of involvement, and no extensive eosinophilia or myocyte necrosis. The indirect endomyocardial biopsy signs of cardiac sarcoidosis are a small collection of histiocytes, microgranulomas, lymphangogenesis, and confluent fibrosis with fatty chains. What is the differential diagnosis that you need to keep in mind when there are granulomas? Obviously, TB. One is TB myocarditis, giant cell myocarditis, arrhythmogenic right ventricular cardiomyopathy can have end-stage granulomas and myocardial fibrosis, and a burnt-out hypertrophic cardiomyopathy or a DCM can present like cardiac sarcoidosis, and an idiopathic VT to differentiate it from cardiac sarcoidosis. Like we saw, okay, when you have pleomorphic VT or a monomorphic VT, which is different from the index pathology, okay, is going to be more suggestive of cardiac sarcoidosis. Now coming to the treatment, there are two things that you have to remember in the treatment. One, is you want to treat the underlying inflammation that is going on, correct? So you would probably want to do immunosuppression. You want to treat the underlying disease, the sarcoid granulomas, which are causing inflammation. So that you will treat by immunosuppression. And second is the treatment of the complications. Complications like heart failure, cardiomyopathy, VT, heart block. Okay. So treatment of the disease by immunosuppression and treatment of the complications of heart failure, VT, heart block. So now treating the underlying disease with immunosuppression. What is the immunosuppression that you will use? You will use corticosteroids. So corticosteroids help in maintaining the LV function in patients who present to you with a normal LV function. Or if they have a mild LV dysfunction, mild to moderate LV dysfunction, it helps in improving the LV function. Okay, so preserving the LV function if the patient has presented to you with a normal LV function, and improving the LV function in a patient who has presented to you with a mild or moderate LV dysfunction. If a patient is in the burnt out stage, meaning he has a severe LV dysfunction of EF less than 30%, that means the disease has progressed to a stage of myocardial fibrosis. So it's not an active stage, it's a chronic stage, right? Fibrosis is already set in. There may be no improvement in the LVEF. Corticosteroids will not show an improvement in the LVEF. There is a good chance, almost a 40 to 60% chance, that the conduction defect, the conduction abnormality may recover. You saw in the 2014 HRS criteria, one of the criteria is cardiomyopathy or a AV block responding to immunosuppressant, right? So there is a good chance that EF recovers and the AV conduction also improves. But the effect on arrhythmias and mortality is still ambiguous. So what are the situations where you will consider immunosuppression? If there is evidence of myocardial inflammation on the FDG PET or on the Dotonac scan with a Movitz type 2 or a third degree AV block with frequent ventricular ectopics or an NSVT, with a sustained ventricular arrhythmia and a LV dysfunction. Correct? So it's simple. You know that LV dysfunction, ventricular tachycardias, sustained ventricular tachycardias and non-sustained ventricular tachycardias, and frequent ventricular ectopics and AV blocks can respond to immunosuppressants when there is an active inflammation. And how do you know about the active inflammation? On FDG PET and the Dotonac. Okay, so these are the conditions where you're going to think of giving immunosuppression. So the treatment algorithm will go like this. You give immunosuppression, prednisolone 0.5 mg per kg per day for 2 to 3 months and go to a maximum dose of 40 mg. You do a PET scan again after 3 months. If abnormal uptake is present, you're going to add a second line drug, second line immunosuppressant, that is methotrexate. If at 3 months there is no abnormal FDG uptake, that means your inflammation has been suppressed. Now you slowly taper down on the immunosuppression, on the corticosteroids. So from 0.5 mg per kg per day, you step down to 0.2 mg per kg per day for 9 months. And then taper and then stop. So just gradual tapering and stopping of the immunosuppression. So if no abnormal uptake is present, you are tapering down on the prednisolone from 0.5 mg per kg to 0.2 mg per kg. Taper and stop. Total treatment you've done for 12 months. Now after stopping the treatment, again you repeat a PET scan at 3 months. At 3 months, if there is no relapse, very good. You will just follow up on ECG and echo at 6 months, 12 months, 24 months, 36 months after stopping the treatment. And you will consider doing a PET scan again if a new conduction defect comes up, or a new LVEF decrease develops, or a new arrhythmia develops, ventricular arrhythmia develops. Okay. But if there is a relapse after stopping prednisolone, you see that there is a relapse again at 3 months. Now you will start with methotrexate plus a low dose prednisolone. So you will already add on to the second line of immunosuppression. And then adjust the doses depending upon the repeat PET scan at 3 to 6 months. Okay. So you start with prednisolone 0.5 mg per kg per day, maximum dose of 40 mg for a period of 2 to 3 months. You do a PET CT at 3 months. If there is abnormal intake, you start on with the second line immunosuppressant like methotrexate. If there is no abnormal uptake, you will taper prednisolone over 3 months, decrease to 0.2 mg per kg for 9 months, slowly, gradually taper prednisolone and stop prednisolone. Okay, so the total treatment with immunosuppression has been for 12 months, for 1 year, followed by which you will repeat a PET CT at 3 months. If there is no relapse, you will just follow up on ECG and echo at 6 months, 12 months, 24 months, 36 months, okay, after stopping treatment. And you will consider doing a PET scan again if the patient develops new LV dysfunction or new conduction defect, an AV block, or a new ventricular arrhythmia. And if you say that there is a relapse, you will start with a dual immunosuppression, a second line methotrexate plus a low dose prednisolone. Again, repeat the PET scan at 3 to 6 months, and you will keep adjusting the doses according to the PET scan report. What is the immunosuppression that you use in in cardiac sarcoidosis? The first is glucocorticoids, prednisolone. The second line agents are methotrexate, mycophenolate mofetil, azathioprine, leflunomide. The third line agents are infliximab, rituximab, adalimumab. And the fourth line is JAK2 inhibitor, tofacitinib. So we saw the treatment of the disease by immunosuppression. Now the treatment of the complications, heart failure and the conduction abnormalities. So first, the treatment of conduction abnormalities. You treat them similar to what you would treat a normal patient with conduction abnormalities. VT or AV block. The only difference being that you would probably want to add an immunosuppressant if there is evidence of active inflammation by FDG PET or by gallium protonate scan. As for AV block, if you decide to pace the patient, you should rather pace the patient even if the AV block resolves transiently by immunosuppression. And the device that you will put in would be preferably an ICD because it prevents the risk of sudden cardiac death, which is very high in patients with cardiac sarcoidosis. As for ventricular arrhythmias, again immunosuppression if myocardial inflammation is present. Routine management with antiarrhythmic drugs like amiodarone or sotalol, along with immunosuppression. Catheter ablation if this VT is refractory to medical management. But catheter ablation also is not always successful. A meta-analysis of 15 studies involving more than 400 patients has shown that patients reported freedom from recurrence 45% of the first ablation and 63% of the repeated procedures. 63% of the patients had to undergo repeated procedures before they had freedom from recurrence of VT. A VT ablation helps to control incessant VT or a VT storm. And if the VT is refractory to medical management, to catheter ablation therapy, bilateral cardiac sympathectomy can be considered. For the prevention of sudden cardiac death, which is a 10% risk over 5 years in a patient with clinically manifest cardiac sarcoidosis, the 2022 ESA guidelines say there is a class 1 indication to put a ICD in patients with a history of prior aborted cardiac arrest, documented spontaneous VT, or a LVF of less than 35%. There's a class 2A indication if the LVEF is greater than 35%, and there is an indication for a permanent pacemaker. So if any which ways you're going to put in a device, might as well put in an ICD. If there is an inducible sustained monomorphic ventricular tachycardia in the electrophysiological lab in a patient with a LVF of 35 to 50% and a minor LGE on CMR, and an LVF of greater than 35% with a significant myocardial LGE on CMR after the resolution of an acute inflammation. So class 1, if there is a documented VT, it's an aborted cardiac arrest, or the LVF is less than 35%, and it's a class 1 indication. For class 2, if the LVF is more than 35%, but the patient has an indication to put in a pacemaker, rather put in ICD rather than only a pacemaker, because the patient may require an ICD later. Second, class 2A indication, if you see that there is a inducible ventricular tachycardia and there is a minimal LGE on the CMR, but the EF is greater than 35%. Okay, and again EF greater than 35%, but not minimal but significant myocardial LGE on CMR after the resolution of acute inflammation. That means this has gone into fibrosis. LGE is present means there is myocardial fibrosis. Correct? So these are the indications for putting in an ICD in a patient of cardiac sarcoidosis. And class 1 indication is basically for secondary prevention, because that a patient is having a monomorphic VT or EF is less than 35% and he has had an aborted sudden cardiac death. It's a class 1 indication, secondary prevention. For a primary prevention is the class 2A indication. EF more than 35 but with the indication of permanent pacemaker. EF more than 35 with a minimal LGE on CMR but an inducible ventricular tachycardia in the electrophysiological lab. And the EF of more than 35% with a significant LGE on CMR after the resolution of active inflammation. Now for the treatment of heart failure, you have the guideline-directed medical therapy, ACE inhibitors, ARBs, MRAs, beta blockers, and ARNI. Immunosuppression is done if there is active inflammation. Cardiac sarcoidosis related to fulminant myocarditis, you give aggressive immunosuppression with IVIG and mechanical circulatory support. For a burnt out cardiac sarcoidosis whose EF is less than 30%, it's not going to improve with immunosuppression. You will give the patient the option of cardiac transplant and a left ventricular assist device as a bridge to cardiac transplant. And the post-transplant survival is as good as the non-cardiac sarcoidosis transplant patients. So the treatment of heart failure is basically like any other heart failure, right? With all the guideline-mediated, all the 4 pillars of heart failure. Immunosuppression if active inflammation present on cardiac imaging. If it is a fulminant myocarditis, you will give very aggressive immunosuppression with IVIG also. And fulminant myocarditis, the LVF is going to drop, so you might have to give mechanical circulatory supports. If it is a completely burnt out CS with no chance of recovery, you give the patient an option of cardiac transplantation. and the post-transplant survival of such patients is equally good. It's as good as non-cardiac sarcoidosis transplant patients. The prognostic markers for cardiac sarcoidosis include the extent of myocardial involvement. Right, so you see for the LVEF, you see for the RVEF, the right and left ventricular functions. The lower the functions, poorer would be the prognosis. You see the LGE on CMR. LGE is basically myocardial fibrosis. More and more myocardium is going into the burnt out stage. So that also is a poor prognosis. And the left ventricular GLS, the global longitudinal strain. Lower the global longitudinal strain, worse would be the prognosis. So the right ventricular function, left ventricular function at presentation, the GLS at presentation, and the LGE on CMR. Second, the clinical presentation. If the patient presents to you with arrhythmias, sustained VT, or heart failure, they have a poor response to immunosuppression. AV blocks have a better response to immunosuppression. So if patient presents to you with a sustained ventricular tachycardia or heart failure, it will be a predictor of poor clinical outcome. In a de novo and clinically isolated presentation, so if it's only a cardiac sarcoidosis, you may have a delay in the diagnosis, and therefore by the time you diagnose, the patient has reached to an advanced disease. What are the long-term outcomes? Cardiac sarcoidosis has a poorer prognosis than patients without cardiac involvement. So extracardiac sarcoidosis has a better prognosis than patients with cardiac involvement. The cause of death is most likely sudden cardiac death due to VT or heart failure. There is a very high 5-year mortality, which is approximately 50 to 60% despite immunosuppression. But because the heart failure therapy has improved, we have newer drugs which are coming up for heart failure. The wider use of ICDs, and because of the wider use of ICDs, the current 5-year survival rate has gone up to 90%. So the 5-year mortality rate was very high, 50 to 60% in spite of immunosuppression. But because of the newer anti-failure medications that have come up, and because of the wider use of ICDs, the 5-year survival rate has gone up to 90%. Thank you.